So welcome to the final session of the our conference, and I think that we all will be excited to hear the upcoming lectures from on the topic of the common movement disorder in Indochina region, which will be given by Professor Norlina Mohammed Ibrahim from Malaysia. And she very well fit with this topic on several reasons, but importantly, she is a part of our task force of movement disorder in Asia, which is under the MDS Asian Oceanian section, and even more important that she will become the chair of this task force. So she very well fit for this topic, and welcome you all to this lecture. I understand that this is pre-recorded and it will be played right after this. Norlina, welcome. Good to see you, even though virtually.
Good to see you, Rongroj. Thank you for the kind introduction. Sorry I couldn't be there.
Not the problem. Okay, would the lecture be ready? Oh, she's doing a live lecture? Oh, Norlina, this is my apology. Are you doing the live lecture? It's not pre-recorded, is it?
No, I actually I had pre-recorded, but if you would like me to do it live, I can also do it live.
Okay.
I thought pre-recorded will help with the videos. I'm just worried about the videos.
I think we'd love to see you live, actually. Yes.
Is
okay.
That so? So just give
All
me
right.
one.
Okay.
One second. I will do it live then.
Thanks so much, Lina, because I was told initially that it was pre-recorded, but you know, we'd be even happier to have your live lecture.
Okay, I will share my screen now. Okay, I hope the videos play well. If not, we will probably could switch to the pre-recorded. You can hear me well, right? Yeah, okay.
We do.
Okay. Let me give you a share screen. Right. A very good morning to everyone. I am Norlina Mohammed Ibrahim. I'm a neurologist from Malaysia, and it's an honor, and it's very nice to be virtually in this conference for the first time. And thank you, Professor Rongroj and Dr. Tai and the organizing committee for inviting me. My lecture is on common movement disorders in Indochina, and there are a number of topics that have been already mentioned, so please bear with me. There might be some repetition. Just allow me to start my lecture. So let's go back into the history of Indochina. Indochina was coined in the 19th century, signifying the Chinese and Indian influence in this region. And we are part of Indochina, and we consist of 6 countries: Cambodia, Laos, Malaysia, Myanmar, Thailand, and Vietnam. And we're also known as mainland Southeast Asia. And our population is approximately 243 million. And our ethnic group consists of Austro-Asiatics and Austronesian. And we have a similar cultural practices, although our ethnic group is relatively diverse. So it's interesting to study the cultural and influences of India and China in this region. So some of the movement disorders will be influenced by this, our ethnic group in this region. So so this is just a nice, colorful slide which shows the colorful cultural practices and heritage. And I hope I've captured all the thank you in all the languages accurately. I may not know how to pronounce them, but that's it. It's a very beautiful region. So just when I was researching on what's common in this region, we need to see what's common globally. So movement disorders, and as you know, as you have seen, can be a manifestation of many neurological conditions. And this is a figure taken from the global burden of study, Global Burden of Neurological Diseases published in the Lancet Neurology. And you can see that stroke remains the commonest neurological disorder, which leads to death and disability adjusted life years. And if you see Parkinson's disease, it's very small there, but it still contributes to burden of disease and death. But having said that, movement disorders could be a manifestation of any of these diseases. So when I wanted to look at what are the common movement disorders in this region, I came across this very nice paper by our colleagues in Myanmar. It's a paper published from patients admitted in Yangon General Hospital. And basically what they looked at was they looked at the frequency of various neurological disorders combining inpatient and outpatient. And again, cerebrovascular disease and CNS infections tops the list. And for the movement disorder, you can see Parkinsonism, hyperkinetic movement disorders, and cerebellar ataxias and hereditary spastic paraplegias contribute to referrals. But if you see collectively, their percentage is rather small. So when I was given this talk, I was thinking about what shall I talk about? So I have divided the movement disorders into genetic and non-genetic. And because the prevalence of genetic movement disorders in this region is not really well known, I've decided to focus on non-genetic movement disorders. And we can divide these into three broad categories. First, looking at diseases that are more prevalent among Asians, whether they're metabolic, vascular, or infection. And we could also look at unique or culture-related disorders. And common disorders globally would still be common in this region because by virtue of it being just the commonest disorder like Parkinson's disease and so on. So let's start with the first group. So for this, I have a number of case illustrations, and I know there are some of the disorders have been mentioned previously, so please bear with me. So let's go with the first case. I think all of you are experts now. I hope my video plays well. So this is a 45-year-old patient with diabetes and hypertension who presented with right-sided involuntary movement. And this is very classical. You saw this and you probably know the diagnosis already. So it is certainly irregular, random movements, which is somewhat dance-like, involving his distal lower limb and also partially his upper limb. So this is hemichorea. So let's go on. So this is his CT brain finding, and his random blood sugar was 25 millimoles per liter. And so this patient certainly has hemichorea, hemibolism, and hyperglycemia, also known as diabetic striatopathy. And diabetes is actually a very common disorder in Malaysia and I'm sure in parts of Indochina. And because diabetes is very prevalent in our region, we need to recognize this syndrome. And it was first described in 1960 and has been reported to be more common in Asians. Up to 70% of cases reported occurred in Asians. And it's caused by hyperglycemia, but it's can also happen with the administration of high-dose steroids. So it's not always hyperglycemia that causes this. It can also happen in patients who are given methylprednisolone and so on. Estimated prevalence is about 1 in 100,000, and the patient usually presents with acute or subacute hemichorea or hemibolism in an arm-leg distribution, but rarely it can be bilateral chorea or monochorea, alternating hemichorea or generalized chorea. The chorea typically responds to the treatment of hyperglycemia, but in some cases, it may require other medications to suppress the movements, especially if it's quite persistent. So the the medications that we use here is typically dopamine antagonists, but we have moved away from that and started to use tetrabenazine. It's not widely available in Malaysia, but we have to bring it as an import permit license. So now we are able to use tetrabenazine, and clonazepam sometimes might work. So the pathophysiology is due to decreased cerebral blood flow to the basal ganglia, causing reduction in the striatal GABA activity and increased in the pallidal activity. So if we Just look at the MRI changes. You can see the MRI shows hyper-intensity on T1 with corresponding hypo-intensity on T2. And I think we all are well aware of this syndrome already. So let's move on to the second case. This is a case of a 60-year-old man with diabetes as well, also has end-stage renal failure on regular dialysis, who presented with involuntary movement for 3 months. He has no family history. Kanan boleh ke depan dua. Sentuh hidung. Sentuh jari. Sentuh jauh. Sorry about the video. It's trying to see. Boleh tak saya minta Encik Hamzah tahan, jangan gerak langsung. Actually, what I'm asking him to do is to try and suppress. So he actually could suppress it reasonably well, but what he had was a generalized chorea, which was quite subacute. It had occurred for 3 months, and we had done all investigations, including manganese level and so on, and looked for acanthocytes. It was not present. And what we found was, we saw this on his brain imaging. So we could see this bilateral symmetrical basal ganglia lesions. And you can see in the diffusion weighted imaging, there's no restricted diffusion. So we were a bit puzzled. We knew obviously this is a metabolic condition because it seems to be swollen, but we cannot figure out why exactly this patient had this. So when we looked up the literature, so when we see any bilateral symmetrical basal ganglia lesions, of course, we have to go through some differentials. For example, carbon monoxide poisoning, mitochondrial lesions, Wilson's disease, whether the patient has had extrapontine myelinolysis or hypoxic ischemic encephalopathy. So this patient had neither any of those conditions. So what he has is a syndrome of symmetrical and bilateral basal ganglia lesions in diabetic end-stage renal failure. And we recently did a systematic review on this, and it is an uncommon condition. And first described in 1998, it can present with acute movement disorder, which presents exclusively in patients who are on dialysis or with end-stage renal failure. And usually patients, in 99% of patients, they also have diabetes. Patients may present with Parkinsonism or chorea and tremor and gait difficulties. So while we are collecting our cases, we came across 3 patients in our center, and then we had 2 more from other centers. So we compiled these cases and conducted a systematic review. So why this happens, it's thought to be related to acute severe uremia and the shift in the uremia, in the urea levels, with a combination of diabetic microangiopathy and subclinical hypoglycemia. So most cases resolve following regular or more frequent hemodialysis, but relapses have occurred. And even the MRI lesions can regress and recur again. So the diffusion weighted image and the susceptibility weighted imaging indicate that this could be vasogenic edema related to metabolic changes or metabolic shifts. As you know, the basal ganglia structures are very vulnerable to toxic changes because of their high energy requirement. So it could be, this could explain why the patient developed these lesions in the basal ganglia. So this is just to illustrate the recurrence of lesions. You can see in the topmost scan, there was this lesion, and then in the second one, it has regressed, and then it recurred again, and then it regressed again. So what we did for this patient was to make his dialysis more efficient. We spoke to his nephrologist and we asked his nephrologist to optimize his dialysis, which somewhat improved the condition. And we had a few other cases. Another patient had presented with Parkinsonism, but the patient was lost to follow-up. So basically what we need to do is to improve the dialysis efficiency. Maybe you need to improve the frequency or change the membrane and so on, but we need to discuss with the nephrologist about that. So this is our review, which was published recently in the Journal of Movement Disorders. And I said we have found 72 cases reported, and more than 50% occurred among Asians. And the treatment is to have a more regular and efficient dialysis. And in 1/3, there was a complete clinical resolution. And in 1/3, another 1/3, there's radiological resolution. So this is next case, moving on. This is a young man in his 20s with sudden onset of involuntary movements, which were intermittent. So again, I think you would know the answer, because a young man with involuntary movement, oops, sorry, you found the answer, but anyway, never mind. So this is a, so you can see again, our theme today is Korea.
Okay, now 100 minus 7 again.
The voice of Dr. Chi, I think he's here. So basically, we're asking him to do mental tasking to see whether the movements will alter. So asking him to count backwards from 100. And you can see the movement is persistent in his right leg. When we're assessing involuntary movement, we should look at it at rest and look at what type of movement it is. He is completely aware it's not a seizure. I mean, you could have focal seizures, but this doesn't resemble any motor seizures. And there's no weakness. He just has this distal movement involving his right side. And obviously, being young, we screened him for everything. And when we did the MRI, there was some scattered white matter lesions. And we proceeded to doing MRA and time of flight, and found multifocal stenosis of the bilateral MCAs, which was more significant on the left side, and short segment occlusion of the left M1 segment with the moya-moya-like pattern of collateralization. His distal ICAs were normal. So what this patient had is moya-moya disease associated with hemichorea. It is rare, but it is something that we should not miss, especially when patients present with hemichorea, and they're usually young. And to date, there are about 17 case reports, and it's thought to be due to reversible striatal hypoperfusion on SPECT, although there are more recent PET studies showed that this moya-moya syndrome leads to abnormal functional connectivity in the basal ganglia thalamocortical circuits. But we're not sure whether this is due to hypoperfusion or hyperperfusion. So it still can be debatable what really causes this hemichorea in this patient. As you know, moya-moya disease is a chronic progressive occlusive disease of the circle of Willis and surrounding vessels, causing the formation of weak collaterals with increased risk of stroke. And we know that East Asians have a higher prevalence of moya-moya disease, particularly Japanese. And given the Chinese ancestries in Indochina, I believe that we would have a higher prevalence of moya-moya disease in this region. And there was a study which compared ischemic stroke and moya-moya disease, and they found that being Asian confers a higher odds ratio of having stroke due to moya-moya disease. So this is something that we need to bear in mind. And there is a genetic predisposition for this, which is in the RNF123 gene. And this particular variant, the variant R4810K, is observed only in the Japanese and East Asians, but not in the Southeast Asian cohort. So we need to look for our own variant with moya-moya disease. So let's move on to the next group. So there's infections, of course, we being in this region, we are prone, we have a high prevalence of infections, particularly Japanese encephalitis, dengue virus, Nipah virus, Zika virus, and of course the other endemic infections. We also very common tuberculosis infection, parasitic infection, neurocystic sarcosis, bacterial infections. They can all lead to movement disorder. They can be acute and reversible, related to inflammatory changes, but when there's striatonigral necrosis, such as in Japanese encephalitis, you can have persistent neurological deficits. And also if there are any lesions, it can also lead to neurological deficits. So Japanese encephalitis is an inflammatory disease of the brain caused by Japanese encephalitis virus. It's common in certain parts of Asia. I think Vietnam, Cambodia, and Thailand is more than Malaysia. Malaysia, the cases have reduced tremendously due to vaccination, but we do see isolated outbreaks, especially in East Malaysia, Sabah and Sarawak. And the movement disorders can be divided into acute phase or more persistent phase due to bilateral nigral necrosis. So I'd like to share a video from this publication by Agarwal in MDCP 2021, which gave a video anthology of all the infection-related movement disorders. It's very, very interesting. And this is something that I think we need to be aware as well. So let's look at, look at the video.
Persistent movement disorders due to Japanese encephalitis. Segment 1. 4-year girl developed acute Japanese encephalitis, bilateral nigral necrosis, and levodopa-responsive Parkinsonism with motor fluctuations and dyskinesia. Therefore, levodopa was replaced by dopamine agonists. 4 years later, during dopa off phase, she has Parkinsonism and generalized dystonia. She looks unhappy. There is dramatic on with rock and roll. The response is sustained. Segment 2. 4-year boy developed acute Japanese encephalitis, bilateral nigral necrosis, and levodopa-responsive Parkinsonism with motor fluctuations and dyskinesia. 4 years later, in the dopa off phase, he is unable to hold his neck, stand, or walk due to hypotonia, Parkinsonism, and left hemidystonia. There is dramatic on with rock and roll. Segment 3. 4-year boy developed acute Japanese encephalitis, bilateral nigral necrosis, and severe generalized dystonia. 18 years later, he has persistent generalized dystonia. Right side is more affected. With levodopa, there is dramatic improvement.
So I'll stop there. So we can see that this Japanese encephalitis can lead to persistent neurological sequelae, but they're quite responsive to medications in these 3 cases. Levodopa in this last case and dopamine agonist. So this is something that we should consider when we're treating patients. So let's move on to the next case. This is a very easy case, but let me see. Oops. Unfortunately, I cannot play this video, but okay, it's probably in the recorded one, but not here. So this is a middle-aged man with unilateral involuntary facial movement. What I wanted to show was this, he had this clonic contraction of his right face and also his right-sided eye, orbicularis oculi, and face, and what he has is hemifacial spasm. Hemifacial spasm is not really a true movement disorder, but it is thought to be a segmental myoclonus. It's not a true spasm, but it's thought to be due to compression of the cranial nerve 7 by arterial lobes within the posterior circulation at the pontine exit, leading to aphatic transmission. Why I brought this here is because it is also a movement that is common, thought to be more common among Asians. So there are no epidemiological studies, but there are support from published studies from within Asia, and a study which had looked at the patients who presented with hemifacial spasm in the Baylor College of Medicine. So they found that Asians were more likely to suffer from hemifacial spasm compared to non-Asians. that was from their center. So they postulated that hemifacial spasm is more prevalent in Asians. And why is that so? Perhaps it's due to the smaller posterior fossa cranial volumes in Asians. And certainly the study by Chan in neurology from Singapore showed that females have indeed smaller posterior fossa volumes. And we know that hemifacial spasm is slightly more common in women. Also, perhaps there is a genetic predisposition or anatomical reason for hemifacial spasm to be more common in Asians. So this is just to share with you this interesting Babinski sign. So whenever you see a patient with hemifacial spasm, there is an elevation of the eyelid when the patient tries to close his eyes. So this is a Babinski 2 sign described by the person, the Dr. Babinski. So it has a very high sensitivity and specificity to distinguish between hemifacial spasm from, hemifacial spasm from blepharospasm. So they will, as they try to close their eyes, the ipsilateral eyelid will elevate. Okay, let's move on to the next, the second syndrome. So this is a unique and culture-related syndrome, and then we'll go to the next syndrome after that. So cultural syndrome, this is very interesting. And this is a video shared with me by Dr. Lim Tian Tian, who's here. So it's a very interesting video. It's a Malay man. He says he cannot control the movement, and he's very, very happy about it. And he drops his paper. He does apoplexia. Again, he drops his paper, and he's very happy. You can see that the amusement. So there's forced obedience, there's vocalization. So he's been asked to look, and he just looks. And then there's coprolalia as well. Okay. This is the next patient. This, I believe this is an Indonesian lady. Whenever she gets startled, she just speaks. So forced obedience. She's been examined by Dr. Lim. Staying there. So there's a lot of vocalization, startle reflex, and they're very startled and they get very jumpy. And this is what we know as Latta Syndrome. And it's called Yaon in Myanmar and Batsi in Thailand. It's a culturally stereotyped neuropsychiatric startle behavior. And usually it responds to variable and sudden and unexpected external stimuli, as you can see, resulting in echolalia, coprolalia, palilalia, involuntary vocalization. Sometimes what they say does not make sense, echopraxia, and forced obedience. It was previously known as the malady of the Malays and typically occurred amongst the Malay women of Malaysia, of the Peninsular Malaya at that time, and Indonesia. And there's exaggerated nose tap head retraction reflex in some patients, which is a hallmark of hereditary hyperexplasia. So there's no specific treatment for Latta. Usually we involve the neurologist, psychiatrist, psychologist, caregiver needs to be informed, and nurses. What is Latta really a neurological disorder? You know, sorry, this is just to show you the head retraction reflex of the startle syndrome before I go on. So just share with you this video on how to perform this. So you can see you can tap on the nose and the patient will retract his head. And this is a hallmark feature of startle syndrome. And it doesn't, they don't habituate. They keep retracting their head. And this is another patient. So if you do this to a patient with Latta syndrome, they would have exaggerated reflex. Okay, that's fine. Okay. So what is Latta syndrome? So it is, again, it's thought to be a neuropsychiatric disorder. And the patient, as you can see, are very, very amused by it. Unlike tics, where patients would be a little bit upset by the tics. So Latta syndrome, are they a form of tics? We don't think so. Or Tourette syndrome, because of the vocalization. It's quite different, because Latta syndrome is stimulus induced and not preceded by premonitory symptoms. And echopraxia and echolalia are not feature of tics. And the suggestibility of movements, which favors a psychogenic cause. And yeah, actually, there's a very nice review by Dr. Lim Tian Tian, I think was shared previously, that shows the component of Latta syndrome. I think Professor Rong Roach is also the author of this very nice review on Latta. So to be honest, I don't see too much Latta now in my practice, but I think we still see it here and there. So it's important to recognize that in this region. So let's move on to the last syndrome. Last disorders, actually, because I thought we should still talk about common disorders worldwide that would still be common in this region. So I would like to highlight a few reversible movement disorders that we need to be aware of, and some of them have been mentioned. So just to go through quickly, this is a 33-year-old lady who's pregnant, presented with balance difficulty and hyperemesis gravidarum. And if you look at her eye movements, so she has horizontal nystagmus and vertical nystagmus. So when we do the finger nose testing, she definitely has a cerebellar syndrome, and she's not able to walk. And so what do you think this patient has? I think it was mentioned previously. So don't think I can hear anyone. So I will give the answer. Yeah, the patient has Spernicus Encephalopathy due to vitamin B1 deficiency. And we know that this is a triad of encephalopathy, ataxia, and ophthalmoplegia, and usually occurring in chronic alcoholics patients who are malnourished. But we do see that currently in patients with hyperemesis and post-bariatric surgery, now that it has become a treatment for obesity. And in crowded camps, actually, we have seen a few cases of Spernicus Encephalopathy in patients who, unfortunately, refugees who traveled across the land to enter Malaysia, and they were staying in crowded camps. So this is something that we need to recognize. And you only need 2 to 3 weeks of no intake of vitamin B1 to develop this Spernicus Encephalopathy. And the MRI changes are characteristic: hyperintensities in the periaqueductal gray matter and the dorsal midbrain regions. And it's reversible and treatable with vitamin B1 injection, with thiamine injection. So let's look at this, another case. This was an interesting case I saw of an 80-year-old man who was still able to cook. He loves to cook. He was cooking for himself, but for the last 1 year, he was not able to do that. And he came to me, and this movement was not noticed by his family members. They just thought he had some difficulty with balance. But when I saw him, there was this subtle finger movement at rest. His eyes are open. It's not closed. So he's doing the counting backwards to see whether the movements are accentuated. Again, his eyes are open. So he has chorioatetoid movement. So let's see how he does this. Asking him to touch his. So he doesn't have much ataxia, but he does have this chorea, distal chorea, and some athetoid movement. But interestingly, his movements are present when his eyes are open, unlike the pseudoathetosis that you would see in vitamin B12 deficiency. So he had absent reflexes, and he was found to be anemic with macrocytosis, and his vitamin B12 levels were low, and he was positive for antiparietal cell antibodies, and he had pernicious anemia, which was late onset. So we treated him with vitamin B12, and this is his movement. Now it's much better. He can resume his normal activities, and the distal chorea athetoid movements have resolved, almost resolved. Okay, so these are the two reversible movement disorders that I thought I'd like to highlight that we still may see because of it being common. And okay, just before I end, I would like to just talk about common disorders around the world and the phenomenology of it. And we can divide, as you know, movement disorders into hyperkinetic movement disorder or hypokinetic movement disorder. And what's common in these categories would be tremors, dystonia, tics in young adults, and tardive syndromes. And I think we have seen quite a lot of examples of Parkinson's disease and secondary Parkinsonism yesterday. So I would just go through very briefly about tremor, dystonia, and tics, so that we're just aware of the phenomenology again. So this is a middle-aged man who came to me with a worsening of tremor. Sorry. And he says he has difficulty walking because of the tremor. And there is a strong family history of tremor in his family, in a dominant history. So you can see he has tremor. Let me have a look at the video.
Kaki tak ada bergerak Kaki tak ada bergerak.
I'm asking about whether there's any tremor in his feet. Okay, so this patient has tremor on posture and action. It's not very prominent, as you can see, but there are some components of the tremor which appeared jerky. So I was worried whether there could be a myoclonus component on top of it. On top of that, he had fasciculations as well in his tongue, and it was a very puzzling case. And he was also positive for Kennedy syndrome. And when we did his genetic testing, he was positive for autosomal dominant tremor type 5, sorry. So he has two genetic conditions which confused us for some times, because he said his tremor is much worse than his family members because they just have mild tremor. So we explored this condition. So he had two conditions put together that caused a worse neurological disease compared to his family member. So this is another young man who presented with adult onset dystonia, and this is something that we will see very frequently. Usually dystonia in the adulthood is idiopathic, no trigger, but in this man, it's related to frequent weightlifting. He goes to the gym a lot, and he said it started one day after he did his weightlifting, and a lot of pain. And it's just a very short video, and you can see the left torticollis to the left, some rotational component. And so this is something that we would encounter quite frequently as well in our region, regardless of where we are. So this is secondary dystonia. And lastly, before I end, this is, if it's a young patient, this would be the commonest movement disorder that we see. A young boy with irregular, involuntary movements, which are random. They're not myoclonus because they're just, they're a bit too, myoclonus has to be shorter. So this is a bit more complex and multiple. And we need to, of course, when we see this, we need to check for suppressibility, and we don't have that video. I didn't capture that on video, and this is partially suppressible. And there is premonitory urge consistent with tics. And similarly with this young man, also complex motor tics. And this would be common movement disorders in this region because of the age group and so on. So I think I'm not sure if I've reached my time, but basically I'd like to summarize here that Indochina has rich history and culture with both Indian and Chinese influences. And certainly that movement disorders that are commonly seen may reflect the prevalence of underlying diseases. So for example, diabetes, metabolic diseases, infection, and stroke would still be common in our region. And of course, being the lower income, we fall within the low to middle income countries, and we would still see metabolic causes related to malnutrition and so on. So we need to recognize that, and not forgetting the unique cultural syndrome. With that, I thank you for your attention. Terima kasih. Come on.
Thanks so much. Thanks so much, Professor Ibrahim. You very well highlighted different disorder, with a good case collection. Really, it's impressive. Any questions from the audience or even online for Professor Ibrahim?
Thank you, Professor Mohammed Ibrahim. Your talk is fascinating for me, very comprehensive, and I would like to have from your opinion about the cause of Latta syndrome in Malaysia. Maybe genetic, the Latta syndrome. And the second one, my second question is about the reversibility of dystonia and Parkinsonism in many cases of young patients with affected by Japanese B encephalitis. There's open the imaging. There is a necrosis of the substantia nigra, but there is a complete reversibility. How can we explain this phenomenon? Thank you.
Okay, these are two very good questions. So the first question on Latta syndrome, there was a hint that it could be genetic, but I don't think we were able to discover any genetic mutation in patients with Latta syndrome. But what we know now, it seems to be a very cultural syndrome. I think Professor Rongroj may have something to add. It used to be almost a performance-like syndrome amongst the Malays. So they used to have this syndrome and people would just, respond and laugh about it. It used to be something like they could be termed as the joker of the community. So I think there is a suggestibility to Latta syndrome, suggesting that it is a psychiatric or a behavioral syndrome that can be, that you can learn. However, the startle reflex is a little bit puzzling. That one is suggestive of hyperepixic syndrome, and we need to find out whether they have any mutation in glycine receptor like the hereditary hyperexia. Professor Rongroj or Dr. Lim, would you like to add on that?
Yeah, you're quite right. But since we have the first author with a recent review here, I think I would give that to Dr. Lim to address this.
Yeah. I think very nicely said by Prof. Nordina about Latta. how I started writing this paper was when I looked into, there were a few cases actually presented during the MDS, if you remember, many years back. And when I looked at Lata, it's quite common among Malaysians and Indonesians. And the patient that you saw, the first man there, was actually my staff. It was my attendant when I was working in Penang General Hospital. And it was so common. I had 3 more staffs in the administrative office who also had Lata. So I found it very, when I work halfway, then I suddenly hear a burst of laughter in the office, and I thought, what happened? And I go there and there's, oh, okay. They were actually amused by the Lata from the patient. But when I asked the patient itself, how do you feel about having this burst of symptoms of coprolalia, palilalia, forced obedience, and so on? Although he himself is not really that frightened, but it's stressful when you keep precipitating it. When you keep making him startle, then he gets upset and he gets stressed up, although he laughed over it. So I find that perhaps that Lata, all the description has been described mainly by the neuros or the psychiatric part, but the startle part perhaps is actually a movement disorder, and it's somewhat more to our Southeast Asian region. But there are other regions in certain parts of the world that are described but in a different name, and I think even in Thailand you do have something like that in a different name, and in Japan as well. So if you look at the literature, we do not really have an answer of what is the cause, but I guess it may be either genetic or multifactorial. There are certain comments on some aggravating factors before the onset of the Lata, things like some sexual problems that they had and so on. But these are all just description. And the descriptions were mainly in the psychiatric literature, and it was described by mainly the Caucasians who describe our problems. So I thought that this paper could actually make its way so that we actually concentrate on our own diseases, and perhaps in the near future, we could actually go into the genetics and also the treatment of Lata, because some of the people do have problems with the condition itself.
Thank you. So maybe you're suggesting that Lata could probably even more common in Penang.
We may need to do another study.
You have already 3, staff with this type of the movement.
Yeah. Okay. But there is no family history though, although it tends to cluster in families. We find that, but there is no definite inheritance pattern to suggest that this is a familial, but at least genetic predisposition may be there. So we need to do more studies.
Yeah, probably it's likely to be heterogeneous because the videos of the cases that you show, particularly the second one, the phenotype is quite striking with the predominant startle that you mentioned. Certainly, not sure whether there could be different subgroup that have some genetics influence, or that they're not quite sure.
Yeah, because the 2 videos were different. I agree. Yeah. For the second question on striatonigral necrosis and how there was a great reversibility with ropinirole after many years, I'm also quite puzzled because, to be honest, I don't see too many Japanese encephalitis myself. But we never thought of, we usually give levodopa and dopaminergic medications for patients who have infection-related movement disorders, and usually they respond well despite having lesions in the brain within the basal ganglia. So I'm not sure whether there's a presynaptic terminals dopaminergic are still preserved in these patients. We know that there are some residual terminals which are still present and which it enables the ropinirole to act on it. But we need to have a DET scan, I think, to look at how much, how devastated is the basal ganglia, but we don't have all that. But it's good to know that they respond. I don't know how many percentage though will respond entirely. I think there is a group that will respond, there is a group that will not respond, but it depends on how severe the necrosis is. That's my understanding or my theory. If anyone else would like to add.
Yeah, I think that's a good point that you mentioned. I think that when we look in the literature, the disorder with nigro lesions can be levodopa responsive, and I think that you documented quite nicely with videos that you have demonstrated. But what I'm a bit perplexed here is the development of the motor complications in those with Japanese encephalitis you mentioned, and that is suggesting whether is there any ongoing degeneration after the static lesions following the infection, in which, I don't know if there are any literature looking into that. Is there any evidence at all? But probably it needs some form of the longitudinal studies on those type of patients, if how they actually progress with some of the imaging or even pharmacokinetic studies would be very helpful.
Yeah, agreed. Yeah.
Any more questions from the audience? Okay, but before we end this session, Professor Ibrahim, maybe if I could ask you to share with us about what you are doing with the movement disorder task force on movement disorder in Asia. This is one thing that maybe I would like to ask you to share, because since we are in the Indo-China, we certainly would be a good opportunity to participate in this task force in any ways, the first thing. And then and the second thing is, as far as I understand, that you have some interest in genetic disorder in which it's not much study within the Indo-China. So maybe you have something to share with us, any initiative that you would like to do, and maybe is an opportunity for us to involve.
Thank you very much, Professor Rongroch, for this, giving me this time and space. Actually, I have been working with Professor Rongroch and Dr. Priya in the Movement Disorder Society Asia Oceanic Task Force for the last 2 years. And we have done quite a significant progress in identifying genetic and non-genetic movement disorders that are common in Asia. And this task force consists of members from the Asia Oceanic region, and we have 3 publications that two have been submitted. One is going to be submitted very soon on genetic and non-genetic movement disorders in Asia. But for the second phase, what we plan to do is to look at, in the next 2 years, we're going to look at the burden of neurological diseases within Asia Oceanic region. And particularly we need representative from Indochina. We want to know burden of Parkinson's disease, particularly. We want to know how much how much Parkinson's disease is affecting our patients, and how much resources we have, and what are the capabilities of each centers within this region. And we know that within Asia Oceanic, we have different socioeconomic group as well. We have some countries which fall within the low to middle income country category, and we have some which are very in the East Asia, for example, they are in the high income category. And certainly there will be discrepancy, and we need to highlight this and help each other. And also, as part of my initiative in collaboration, please allow me to share one slide that perhaps which will help. I would like to invite our friends from Indochina. This is a collaboration initiative initiated by Dr. Kin Mok from UCL This is as part of the Global Parkinson Genetic Project, where he has set up an East Asia Parkinson's Disease Genetics Consortium. So you could ask why we are not East Asia, but what East Asia Parkinson's Disease Genetics Consortium is going to do is they're going to look at underrepresented population within Asia. And so far, I think Professor Rongroj, she has approached you, and I know he has approached somebody, a neurologist from Vietnam as well. So we would like to be inclusive and include Laos, Cambodia, and Myanmar as well into this group. And hopefully we can arrange a meeting in Kuala Lumpur to initiate a collaboration, a working collaboration between our centers so that we can enhance the understanding of genetics contribution of genetic contribution in Parkinson's disease within our region. We can have our own publications. We can have an Indo-China group, subgroup publication. We can work on this in the future, but we need to have a meeting. This is just an initiative that I like to share. And I'm also very interested in spinocerebellar ataxia. We have now worked with Indonesian colleagues, but we would like to engage our colleagues in Indochina as well on spinocerebellar ataxia in Asia. And that's all, Professor Rongroj, that I have. Maybe I'll just stop sharing. We can open for discussion.
Thanks very much, Professor Ibrahim. You know, not only we have the Vietnamese colleague in this audience, but we have colleagues from Cambodia and Laos sitting with us too. And I have seen that they already took photographs of your slides, so I think you will be contacted soon.
Thank you, thank you. Thank you for this.
All right, without further questions, I would like to end this session, and thanks very much, Professor Ibrahim. And let's move to the next video case discussion. Thank you. All right, I think we really come to the last session, but probably one of the most exciting one that probably the audience are looking forward to, because we have this interesting video case discussion, and probably Dr. Sringian can share with us how this session has been developed, because it seems to be a really a collaboration by different people across the Indo-China region, and we probably have quite a good cases from our region to show with you, to share with you, and maybe we can get some feedback and discussion from the audience and online as well. Dr. Singen, maybe you share how this session is developed?
Okay, thank you. And this is the last part of our Indo-China Movement Conference. This is the collaboration of the whole country of our region for the presenter and also the case discussion. Yes, and I would like to thank all the faculty and all the presenter who will presented and participate in this part. We have actually 7 cases of the interesting case for this part, but if we cannot finish all the case, it might be 3 or 4 cases, and the other one I will run through it for the whole case.
Okay. So how easy, difficult they are? Can you rate these cases from 0 to 10?
It can vary.
So the audience can be, you know, they can get themselves ready for this.
Some cases you have learned in 1.5 days already, but some case is quite interesting and very interesting, very rare. So you can have a discussion with our faculty too, if you want to try, if you want to exercise your brain again before we finish it.
Okay, so that's exciting. How would you like to do it? Just the presentation, or you would like it to be a bit more interactive so I can go down and ask people?
Maybe a bit more interactive, but we will start with the case presentation and the video presentation. And after that, the faculty, maybe from Myanmar, and Professor Narina and also me will give a short discussion. And if you want to add any comment, you can please please try to add the comment, and then the presenter will summarize the case again,
Okay,
and then
that's
finish
good.
for one case.
So we have the expert panel sitting here as well as online, so
Yes.
that they can give the inputs into the cases.
Okay.
Okay, I'm going to stretch myself walking around too.
Let's start with the first case from Vietnam.
Yeah, good morning, everyone. I'm going to present the first case. This patient is a 17 years old female patient who come to our clinic because of the abnormal involuntary movement of the body. Regarding her history, 3 weeks prior to the admission, she had a sudden onset of restless abnormal movements of the body. Those involuntary movements initially involved the left side, then spread to the other side in few days, and the severity of them gradually progressed and disturbed daily activities. Though movement disappeared during sleep, and throughout the course of the disease, she has been alert, denied any fever or headache. She has complaints of pain in toes for recent 3 days before admission. Regarding the medical history, there's she has a normal perinatal period and a healthy development. 1 month prior to the disease onset, the patient got vaccinated with human papilloma virus and Japanese type B encephalitis vaccine. And 1 week later, she had a fever and mild sore throat, which resolved spontaneously. The neurological examination revealed normal consciousness and no focal neurological deficits, except for a abnormal movements, which is going to be shown in the video. She did have a mild inflammation in the metatarsal and phalangeal joints in the toe. And this is the video of the patient. A closer look at her face. Another video when she walked. Yeah, so what's going to discuss what is the phenomenology of this patient and what are you going to do next?
Okay, good. Really nice case. Who would like to volunteer? Right. So last year, neurology resident in.
I think this patient have a generalized career, and I think this is a young female with the generalized career and joint arthritis. So I think this patient have a symptom, and I think I should do ASLO for this patient.
Yes, thank you.
Here, maybe I would like to introduce Associate Professor Win Min Aye from Myanmar. She joined us from the virtual. Could you please switch to the Zoom? She will be one of the faculty who will discuss this case too.
Right, so maybe we can ask Dr. Ye to comment on the, the answer from the audience here.
Thank you for coming. Thank you for joining us.
Okay. Hello, everyone. I'm Dr. Yemi A from Myanmar.
Welcome.
Nice to meet you all. Yes, the phenomenal in video segment 1, the phenomenology of the patient, the answer from the audience is correct. So the previous lecture given very excellently. They can notice the chorea. So because the movement in this video segment 1, a young girl with involuntary movement of the extremities, which is the movement are very random and irregular. And it's spread to involve the arms, necks, and also lower face. And I also see there is a facial chromazine. And in video segment 2, you can see she walked with very irregular and lurching gait. And it's like dancing. So it is a very typical pattern of the generalized chorea. So the phenomenology is generalized chorea based on the randomness of the movement. And she cannot maintain her outstretched hand in front of her. So she also has motor inconsistent. So correct, the phenomenology is the generalized chorea. So what are you going to do next? So let me share my screen.
Sorry, please wait a minute.
Okay.
Please share your screen with us. You can share screen with us.
Can you see my screen?
Yes.
Yes, we do.
Gary.
Okay. So as I mentioned earlier, the patient has involuntary, continuous, random, and irregular movement overflow to the arms, leg, and neck. She cannot maintain her upper limb in outstretched position, and she also has facial chromazine. In video segment 2, she has an irregular gait. Her movement is very exaggerated when she is walking. So in approach to a movement disorder, as a general rule, the first step is we need to consider what is the phenomenology. In this case, the phenomenology is the hyperkinetic movement and generalized. And the second one is it isolated or combined? So I didn't see any other movement apart from the chorea. And the next one is what is the underlying etiology based on the clinical evaluation and the investigation. So this patient with generalized chorea, so we need to consider the differential diagnosis underlying the chorea. So how to approach this patient? We usually based on the clinical evaluation and neuroimaging and the laboratory workup. There are some particular features in the clinical evaluation: body distribution, age of onset. You need to know family history, and also time course, and associated neurological features, other medical conditions, and medications. Regarding body distribution, if chorea involves forehead, especially forehead, it is typical features to support diagnosis of Huntington. If chorea involves oropacal lingual region, you need to exclude tardive dyskinesia. If a chorea is only in the one part of the body, you should exclude structural condition on the contralateral side. But sydenham chorea can also present with a hemichorea. Okay. Etiology of the chorea can vary according to the age of onset. Like in this patient, in young onset, the hereditary chorea is the most common genetic chorea, and autoimmune chorea is the most common acquired chorea. And so in this patient with a subacute presentation, we should consider autoimmune cause of chorea. Another thing is the time course. It's very important. As a general rule, the acquired or sporadic cause usually come with acute or subacute temporal profile. So in this patient, came with 1 month history, subacute onset, we should consider autoimmune, infection, and metabolic in the first diagnostic list. You don't need to forget about the detailed family history, including 3-generation pedigrees, because some patients have negative family history even though they have a genetic cause. And you also need to look for other associated neurological or systemic features in your history and clinical examination, like abnormal movement, any cognitive dysfunction, any psychiatric or behavioral disturbances, present or absence of KF range, any peripheral neuropathy, and any pyramidal tract or cerebellar signs. And you don't need to, you should not overlook other medical conditions like diabetes and ischemic risk factor in vascular case, and thyroid dysfunction, recurrent miscarriages, and arthropathy and rashes. So the medication is very common cause of chorea, especially chorea in orobuccal and lingual chorea. So you should ask detailed medical history, including neuroleptic, anti-epileptic, benzodiazepine, oral contraceptive, and so on. So I have discussed about the clinical evaluation, and there are some clinical characteristics. When you know about all these things, the next step you need to go is neuroimaging and the laboratory workup. But this neuroimaging and laboratory workup based on the clinical information you have. It includes neuroimaging, laboratory testing, and genetic testing. So in this patient, came with a subacute history in adolescent, without family history, without exposure of any medication, no typical patterns of the chorea distribution, is generalized chorea, no associated neurological findings except arthropathy. So we should consider the autoimmune chorea and sydenham chorea first. So the investigation should be based on these differential diagnoses. So I will ask for the CBC inflammatory markers, thyroid functions, autoimmune profile, and I will also detect the KF range and blood test to exclude Wilson disease, because Wilson disease is common in our region, and if a young patient presents with any type of movement disorder and psychiatric abnormality, we should exclude Wilson disease because it is a treatable condition. So key learning point here is there are a long list of medical, neurological, and hereditary conditions associated with chorea. Importantly, age of onset, particular distribution, and time course are very important diagnostic clues. Negative history does not exclude genetic cause. Autoimmune etiology should always be included in the differential diagnosis, especially in subacute presentation. Lastly, but not the least, it's crucial to identify acquired cause because many of them are treatable. So in this case, that we should exclude autoimmune etiology first. So thank you for attention.
All right, very comprehensive. You have any some of those results available? Proceed.
Yeah.
So we have done several investigations, mostly cover on that holistic investigation recommended by Professor Minton. So this is the MRI of the patient, reveal no lesion. The laboratory tests, including cell blood count, electrolyte, glucose, hepatic or renal function, thyroid hormones also, vitamin B12 are all within normal range. ANA screening and lupus anticoagulant screen negative, no RF ceruloplasmin, normal range. And we have done the CSF analysis, is the normal. We have done several tests, including anti-streptolizin. We have done it 2 times, and both there's no increase in anti-streptolizin. Anti-DNase B antibody, no normal, and NMDA receptor antibody and dopamine 2 receptor antibody also normal. Negative result. So to summarize, this is 17 years old female, has 3-week onset of generalized chorea, prominent at extremity. She had a past history of HPV and Japanese type B encephalitis vaccination. She did have a fever and mild sore throat 3 weeks before, and on the workup resulted negative. So what is the diagnosis and what is therapeutic therapy for this patient would you recommend?
Anyone want to try?
Will you still confirm the diagnosis? This is the synonyms. I think we might need to speed the discussion a bit. We can still have a few questions available. Maybe if I could ask the same doctor who answered, do you still think that this is still synonyms? Are you happy with your initial thought?
Yeah, I think also the SLO is negative, but this patient have the history and symptom like the syndrome chorea, and then I think that the test have the sensitive and specificity is not the 100%. Okay. So I think that.
So you insist this is synonyms, no other differential. Number 1 synonym, number 2 synonym.
Yeah, my first thinking is still syndrome chorea.
All right. Okay.
What about the history? Your first.
And now, how about your answer for the cause of general chorea?
He still thought that that's the syndrome chorea. Yeah.
Okay.
Okay. She has another interesting history, like she has a post-vaccination. Could you a little bit comment? Anyone want to try?
Yeah. Do you want to especially during this COVID pandemic here, many people get vaccines. Could this be possible, the post-vaccination movement disorder?
This patient came to us before the pandemic outburst.
But she has the 2 vaccines before. She has the HPV and the other one is, what other vaccine? This is the other one that she had. Could this be the post-vaccination movement disorder? All right, I think for the interest of time, I think we need to speed up a bit.
Yes. Yeah, with the subacute disease course, we reasonably rule out on the infection causes. So we suspected that this is an autoimmune chorea, and we are started to use the immunotherapy. We use methylprednisolone with 1,000 milligram per day for 3 days, and we use the symptomatic treatment with Respiridone and trihexyphenidyl. And 3 months later, the patient, as you can see in this video, see on the most of her symptom resolve. And we stop using the symptomatic treatment. Yeah. So I'm going to skip those. And as our neurological resident mentioned, they all have a positive the sensitivity of test, but IS anti-streptolizin is positive in approximately 80% of cases, and 90% of them will exhibit positive tests to antigen. And in this patient, we have done 2 antigen, and they are all resulted negative. So what do you think that the final diagnosis of this patient, Sydenham chorea or post-vaccination chorea, or you suggest another autoimmune chorea, and any other antibody that you recommend that we should do?
Yeah. I think to speed this up, I think we should go back to the expert. We have the expert who just commented the case earlier.
Yeah.
Dr. Ye, do you still, what do you think the most likely are based on all these results?
Yes, according to the history, with close relationship to the vaccination, and also in the literature, there is one case report of the chorea movement disorder after HPV vaccination. So my first thinking is it's likely to be post-vaccination chorea, although the antibody tests are all negative.
Okay, anybody else? Any other comments? And the other point that we might want to mention briefly, whether the treatments alter any natural history of this patient at all, or is it really a, are we dealing with a self-limiting disorder in which the treatment might not, change anything that much apart from improve her career with Reversible?
I have some comment for this case. This patient, after 6 months, when I stopped risperidone and Trehas, the patient still stable without symptom. And so in this case, this patient has three vaccination for SPV. Human papilloma virus vaccination, and the third time after 1 month she have the symptom. And in Vietnam we just do some antibody such as NMDAs and D2R receptor antibody. So in Vietnam, I think in this case I most likely to think about post-vaccination chorea.
Right. Okay. I think the other point that instead of we're go through all these fancy antibody panels, so I just wonder if we want to look for do the examination of the heart, for instance, cardiac examination. If there is any murmur or anything that would be suggestive of one way or the other.
Yeah, on the cardiac assessment is normal. Yes, you have a ultrasound. Yeah, cardiac ultrasound normal and normal ECG. Yeah, at the on the question we all suspect of Sydenham chorea, so we do a thorough assessment of the cardiac function.
Okay, what about this polyarthritis? I can't remember all these criteria now, but are they migratory polyarthritis? What this patient has that arthritis, right? Has it been examined? What did you find? Is that metatarsophalangeal joint?
Sorry, I can't say.
Arthritis.
For the rheumatic fever, like arthritis in the rheumatic fever.
Joint examination.
I've done because of my arthritis on her toes. So we have done several like inflammatory and biomarker, but we detect nothing. Normal CRP or VS or RF use it. Everything is normal, and the arthritis resolve in several days without any treatment, or maybe with methylprednisolone.
So it's all subsided for a very short period of time.
Yeah.
Okay.
Thank you. We will move to the second case. The presenter of the second case is Dr. K.O. Wesna from Cambodia. And the faculty for the discussion in this case is Professor Narina Mohammed Ibrahim.
I think we probably need to speed up the discussion a bit.
Yeah.
Yeah, sure.
Firstly, I would like to say thanks to organized committee for inviting me and Professor Chumnabot to join in the conference today. So this is my the first conference of movement disorders that I joined so fast. So thank you for your warm welcoming from Vietnam's committees and Thailand's. Thank you. Today I'm going to share a case, clinical case studies related to acute abnormal movement disorders after acute ischemic stroke. So for this today, I think we also has many video case discussions and many lectures related to the movement disorder, and we also say a lot with the case studies and also the lectures. So I would like to move to my case. My patient, 68 years old female, addressed in Kampot, Cambodia. Her occupation is housewife, and her chief complaint is involuntary movement disorder of the left hand side. For 5 days period to consultation, the patient present with involuntary movement disorder in the left hand and left waist with a mild weakness of her lower limbs for 5 days. She went to consultation with a local medical cabinet, but after the initial treatment, her clinical condition was not improved. Then her family took her to my hospital. So she was admitted. She reported with weight loss around 4 kilograms per month, mild fatigue, and increased urinary frequency for around 3 to 4 times at night. She has no fevers, no cold, no dyspnea, and neither chest pain. So for the past medical history, the patient has over 5 years of history of hypertension and diabetes. Her past medication, she used only amlodipine 5 milligrams 1 tab per day, and metformin 500 milligrams 1 tab in the morning and 1 tab in the evening. For the past medical history, she has no any past medical history of cerebral vascular disease, no history of movement disorder so far, and her family history also not detected any abnormal movement disorder. For the clinical examination, the patient get when come to the consultation, she assessed for the BP with 150. And for general examination is generally normal. The hand normal, heart has no murmurs, the lung is clear, and abdomen source. So the neurological examination, she was alert, oriented with the normal Glasgow. Face appearance is symmetric, no dysarthrias and aphasias, no dyspargias, and no nystagmus. So the motor, she has a mild weakness of upper limbs and the lower limb with 4 over 5 and normal in the right side, and tension reflex is normal. So here's the video of the patient when admitted to my department. with these videos and history and past medical history of the patient. So what is the phenomenology that you think, and what kind of movement disorders that we can discuss together?
A short discussion from the audience, and then we move to the faculty. Would you like to try, Dr. Apasan?
First of all, I see the hyperkinetic movement on her left upper limb, and the phenology is flow light movement. So I think it's Hemifacial Korea. It's only the left upper limb.
Okay. Would you like to try for the etiology or not? Let's please, Professor Ibrahim, could you please discuss in this case?
Yeah, so this is a middle-aged to elderly lady, who presented with acute onset of chorea. It seems to be more predominant in her left upper limb. Her leg, I'm not sure, but it also involves her neck and to a certain extent, her face. So I would say it's a hemichorea. So whenever you see a hemichorea, you need to look at a structural cause or a metabolic cause, considering that this patient has diabetes as well. So the first thing I would want is to know what her blood glucose is. And I would like to know what her CT scan shows to exclude a structural lesion. And usually with a history of diabetes, hypertension, we suspect vascular cause.
Thank you. Maybe you can show the investigation.
So now let me move to investigation. So this patient has hyperkinetic, involuntary, irregular, and continuous flow randomized. So we consider of a less hemichoreas. So for our investigation, the patient was worked up with the laboratories imaging workup. So in OPD, he consults with one more doctor. So he has let the patient to do laboratory tests, ECG, echocardiography, chest X-ray, and M. With this case, we did not take a CT scan, so we assess for MRI without gadolinium. So the result of the test, the patient blood test has a normal renal function with the LDL cholesterol HT6, triglyceride 264. The patient comes with uncontrolled diabetes with HbA1c 12.2% and glycemia 291. The electrolyte is normal and her CBC is normal.
Could you show the imaging?
And for the imaging, we have two slides, so you can see first.
You can
So for the result of MRI, the patient has acute infection in the left body corpus callosum and all small lesions of the periventricular spine matters and of bilateral frontal lobe and the rise of Pertinent. This patient suspect was a small cerebral cell disease. So it has
Just to add, does she have any acute lesion in the right basal ganglia region? I wasn't sure. Was it showed in the diffusion weighted imaging?
Could you please go back to the two previous slides? I think there are no new acute lesion in the right basal ganglion, but only the old lesion for the right side. for the DWI region, for the acute is only on the left side.
Exactly.
So if it's opposite of the hemicoria.
But this patient he has a minor small infection in the right putamen. So in the patient of diabetes, and so in this case, sometimes it is a little bit difficult for us to differentiate if the patient has only chorea due to the ischemic stroke, or it can be the combination of hyperglycemia. So sometimes it can be combined of the both causes.
I agree. I think it's a combination, because the patient already has a disease of the basal ganglia, and perhaps the fluctuation in a sugar control, which may have happened 5 days, because by the time she presented to your hospital, probably the sugar has already come down. I'm not sure what that translates to, because we use millimoles per deciliter, but that's still high, because we have seen cases of transient fluctuation in sugar causing hemichorea. And then even when the sugar normalizes, they still have persistent hemichorea. So it could be a combination of both factors in this patient.
Thank you.
And sometimes in this type of disorder, the imaging abnormalities can occur much later. It might not occur at the onset of the presentation. So the negative imaging certainly is not the exclusion. The other thing is that sometimes this strategic vascular lesion can be very small, and it might not be detected by the regular MRI sequences, because you can, certain slices might, the lesion might be in between slices, for example.
So for the diagnosis of the patient has a hemichoreas with acute ischemic stroke of the left body, corpus callosomes, and cerebral small vessel disease, hypertension, and diabetes type 2 with uncontrolled glycemia. So in this go to management. In this case, we manage with the haloperidol 2 milligrams. 1 tabs every 12 hours. We control the hypertension with a temistotang 40 milligrams 1 tab per day. The patient was given aspirin 81 and milligram 1 tabs per day, and atorvastatin 20 milligram 1 tab per day. The glycemia of the patient was we controlled with dapagliflozin 10 milligram 1 tabs per day, and insulin smitat injection assays. So here is a video after 5 days of admission of the patient. So she partly reduced, she still has some choreas, but not too much as before, and mostly on and off as choreas.
Thank you for the second case. Maybe is the cause from the stroke and also the uncontrolled diabetes, which is the fluctuation of the blood sugar. We'll go to the third case.
Thank you.
The third case is from Dr. Shi Yong Chuan from Malaysia. He already pre-recorded the case. This case is quite very interesting. Yes.
The organizing committee of
Yeah,
the 2022
excuse me,
China
there's no sound.
Conference, chairperson and fellow colleagues. My name is Chi, a neurology fellow from Malaysia, and it gives me great pleasure to be here today to share with you a recent clinical encounter that I've had. We have a 17-year-old Malay gentleman who is studying full-time in a boarding school. He's an average performer in school and has no known medical or psychiatric illnesses. His family and him had just returned from Pulau Langkawi for a family vacation. For our counterparts outside of Malaysia, Pulau Langkawi is well known as one of the mystical islands up north of Malaysia that is rich in exciting myths and also legends. He presented with acute onset behavioral change for 3 days prior to his admission in February this year. It was his first hospital admission. He was confused and disorientated on arrival, demonstrating prominent auditory and visual hallucinatory behavior. His hallucination was very vivid. He was seeing Mashuri and her tomb. And according to Langkawi's folklore legend, Mashuri was cursed by the island for committing adultery. He was also exhibiting disorganized behavior, whereby he was sticking out his tongue inappropriately and was showing Malay self-defense gestures. His speech was also abnormal, where family finds it more formal than usual. He wasn't sleeping and was running around, jumping around middle of the night. And among the few relevant negatives, there was no fever, headache, or any symptoms related to raised intracranial pressure. There was no respiratory or gastrointestinal symptoms, and the family did not report any signs and symptoms of preceding infection. He denied constitutional symptoms, and there was no family history of psychiatric disorder. Particularly, he also denied any substance use prior to his current presentation. On clinical examination, he was confused, disorientated, and psychotic. Affect was blunted and restricted. Eye contact was poor with minimal verbal output. There was no signs of meningism, and examination did not pick up any long track signs. In the next video, I'll be showing the phenomenology of movements that we have picked up during the course of his admission.
Dia rasa apa nak sembelih? Nanti nak sembelih siapa?
In this segment, the mother asked, "Who are you trying to slaughter?" He answered, "I'm trying to slaughter the rat."
Aziz, angkat tangan kiri. Genggam tangan. Genggam.
In this segment, we have asked him to raise up his hands and try to make a fist.
Angkat kaki kiri. Kaki kiri. Okay, letak.
We next asked him to lift up both his legs.
Letak tangan. Aziz, letak tangan. Okay, kita angkat kaki.
Aziz. 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 Aziz.
Okay.
That's all about the video. Next, I'll leave some time for our panelists to discuss on the phenomenon.
Yes, it's quite challenging because it's different from we have learned for the past 2 days.
Yeah, this is a good phenomenology. Pick the right person, right?
So in this video, I'm suspect this patient has a stereotype movement disorder and maybe some catatonia when he keeping position, and I can see well with the mouth, but described in the patient there's a tongue protrusion. So I think this movement is stereotype. And
dia rasa apa nak sembelih? Aziz nak sembelih siapa?
In this segment, the mother asked, "Who are you trying to slaughter?" He answered, I'm trying to slaughter the rats.
Physics. Angkat tangan kiri. Genggam tangan. Genggam.
In this segment, we have asked him to raise up his hands and try to make a fist.
Do you think that he has a stereotypy? And how about
we next ask him to lift up
he wants to grab something. Yeah? Look. He has a hallucination, right?
He also have a vivid hallucination. This is the interesting phenomenon. It has a specific name.
Apraxia,
something like that.
But he did pretty well with the first.
Okay, anyone want to add any comment?
Do you want to add something?
Yes.
That's all about the video. Next, I'll leave some time for our panelists to discuss.
Yes, I think her answer is nearly complete. He has a quite peculiar movement, like move his hand repetitively, try to grab something, and also sometimes it's sustain of his posture, and sometimes his posture continue to some posture that doctor try to set it. This is one of the example of the catatonia. He has called it cataplexy. Is one of the criteria of the catatonia. And another one, when the doctor move his arm, is called flexibility, like your break the wax like this, and this is the one of flexibility. And the last one, the patient copy the posture of the doctor is the echopraxia. It's also the phenomenology of the catatonia. And another one might be he tried to graph some vivid hallucination that he saw. And for the approach, he had the acute onset of behavioral change and also hallucination, including visual hallucination and auditory hallucination, and have a sleep-wake cycle disturbance and the movement disorder of the catatonia. So for the approach, I think we have to categorize into it. Is it functional or is organic? But in this case, I think we can localize the anatomical localization, and the movement and also the behavior is not so complex. So the most likely is the organic cause. So for the anatomical localization might be in the limbic system and also the orbital frontal or dorsolateral frontal lobe lesion. And this is for the anatomical localization. And for the clinical cause, this is quite acute. Might be, I'm not sure for the previous history, anything happened to him or not, because he went to some island in Malaysia. Yes, for this patient, it might be acute to subacute. So you have to think about the infection, maybe infection, inflammation. For the infection of the limbic encephalitis, in this case, might be one of the listing is the herpes simplex encephalitis, and maybe can other viral. And in this era, we have to think about the COVID infection too. But history is no fever, which is quite unsupported the infection. And another one might be the inflammation that can cause like this for the limbic encephalitis. One listing list might be the anti-NMDA encephalitis. that we have learned that also have the catatonia as one of the presentation of the anti-NMDA. Another one might be the VGKC, like or AMPA antibody, encephalitis, and LGI1 and CASPA2. So let's move to the investigation.
On the phenomenology of the movement shown. That includes both organic and psychiatric diagnosis. Autoimmune, we were entertaining a few differential diagnoses that includes both organic and psychiatric diagnosis. Autoimmune encephalitis is top on the list. With new onset psychosis in a young adult, could it be NMDAR encephalitis? The prototypical autoimmune disorder that causes psychosis, confusion, memory loss, and seizure. Infective causes like HSV encephalitis is also known to cause acute behavioral change and psychosis. In a young man who had just returned from vacation, we wonder whether he could have taken any hallucinogens while on the island. Once organic causes have been adequately ruled out, primary psychiatric conditions like early onset schizophrenia and brief psychotic episodes should also be considered. A battery of blood investigations were taken and he was subjected to a lumbar puncture. He was treated as per infective or autoimmune encephalitis with IV acyclovir, methylprednisolone followed by IVIG. However, he remained psychotic after the first line of treatment. He was still having vivid hallucinations. He was restless and had to be put on restraints. He appeared to be in his own world, constantly scanning around. At times, he would be shouting, laughing, and talking loudly. Occasionally, we noticed gesturing of the right hand that resembled Silat, a Malay indigenous martial arts, that we initially thought it was as a response to all the frightening hallucinations that he was experiencing. He was on quetiapine that was escalated sequentially. In view of poor response to the first-line therapy, 5 cycles of plasma exchanges were offered. Following that, we noticed more frequent and prolonged gesturing of the right hand, and his speech and movement became minimal. He, however, remained awake and watchful. With regards to the investigations that we had sent, CSF was essentially normal. Opening pressure was normal and its biochemical constituents were within normal range. Routine blood work was normal as well. CSF analyses for 11 different viruses, including HSV1 and 2, were both negative. Serum autoimmune encephalitis panel, as shown on the left side, including NMDAR antibody, was negative. EEG and MRI were also both unremarkable. Over the course of his illness, we noticed the above clinical features occurred sequentially, fulfilling the clinical diagnosis of catatonia. They are mutism, posturing, waxy flexibility, catalepsy, stereotypy, and echo phenomena. Hence, we decided to give him a test dose of lorazepam at 2 mg and observe for any clinical improvement. This is a video showing you his response after a test dose of lorazepam at 2 mg was given. So with some assistance, he could ambulate and his mentation was back to normal. He was alert, conscious, and was able to converse more coherently. And soon after that, he was back on his feet, able to play badminton with his siblings. The CSF COVID-19 PCR eventually turned out positive. All his family members were later diagnosed to have mild COVID-19 infections. Symptoms surfaced later and all of them were home quarantined. None of them had any neurological manifestation. At this time, the diagnosis now became more concrete, which is COVID-19 encephalitis with psychosis and catatonia. He continued to improve with regular benzodiazepines and we managed to discontinue his antipsychotics upon discharge. Symptoms completely resolved by 3 months, and there has been no residual neurological or cognitive sequelae up to this date. This is the actual timeline of his course of illness. Note that I've shortened the timeline, making it more compact to cater for this presentation. However, I would like to highlight that the catatonia only became prominent or surfaced a few weeks from his initial presentation that was predominated by all his psychotic symptoms. He subsequently responded steadily with regular doses of benzodiazepines and eventually back to his usual self. There are a few pertinent learning points with regards to this case. Number one, catatonia is a neuropsychiatric disorder that encompasses a wide range of movement disorders. Characteristic clinical features are critical to the diagnosis. Catatonia can be seen in psychiatric disorders, general medical, neurological, and surgical conditions, as well as drug and toxic substances. The pathophysiology still remains unclear, and the GABA hypothesis has been proposed. Most of our patients with catatonia respond to benzodiazepines or electroconvulsive therapy. It is important to elicit the underlying cause of catatonia and treat it to ensure early and complete resolution of symptoms. Brandau et al. In his recent excellent review article look into various movement disorders in COVID-19 infection. And among 93 specific cases of movement disorder caused by or acutely linked to COVID-19 infection, myoclonus was present in 63% of patients, followed by ataxia in 38%, action or postural tremor in 10%, rigid akinetic syndrome in 5%, and also oculomotor abnormalities, and that include opsoclonus, ocular flutter in about 20% of patients. I'd like to bring your attention to catatonia, which is a rather uncommon feature in COVID-19 infection, and that constitutes only 2.1%. Hence, it is important to recognize and diagnose catatonia early to allow effective and early provision of treatment to our patients. Thank you all for your kind attention. And now I open the floor to comments and also discussions.
Thank you, Dr. Shi.
A very good morning to the organizing committee of the
This is quite very interesting, rare in the common situation, and we have to try to think about that catatonia is not only come from the functional or psychosis, because if you didn't detect and didn't treat it, will turn to be the malignant catatonia that can be very high morbidity, mortality. Thank you. Let me move to the fourth case. The presenter will be Dr. Warongporn Phirnpathom from Thailand. And again, the faculty who will discuss is Associate Professor Win Min Aye from Myanmar.
So the next case is a 25-year-old female with a chief complaint of progressive generalized stiffness and dysphagia for 6 months. So this is her clinical course. 5 years before coming to our hospitals, she has progressive generalized numbness and tingling sensation. The patient cannot feel the coldness or warmness of the water. After that, 3 years before the admission, there was progressive generalized stiffness, especially at bilateral arms and legs. She could not put the spoon into her mouth when she ate the food. And she also had progressive dysphagia. There are difficulties in chewing food, and the patient developed aspiration when she drank water. Then she went to the nearby hospital, was admitted and treated as demyelinating disease. She was given intravenous pulse methylprednisolone for 1 gram per day for 3 days, and then prednisolone 10 milligrams per day for 11 days at the hospital near her house. However, there was no improvement of her symptoms. 6 months before the admission, there was generalized stiffness and dysphagia worsened. And that was notably abnormal posture of her left hand. She could not clench her left hand to catch an object, and that was also difficulties in opening the mouth. She had significant weight loss of 10 kilograms during these 6 months and no fever was observed. This is her past history and family history. There is no history of drug abuse, recent vaccination, no COVID-19 infection, and all family members had no diseases, including her father, mother, and one brother. So before we go to the neurological examination, this is her systemic examination, which was all unremarkable. The general appearance showed a thin young Thai female, fully alert, and the heart, lung, abdomen, extremity, lymph nodes, and the skin were all normal.
ยิ้มฟันโอเคยิ้มเต็มที่โอเคอ้าปากกว้างๆนะครับอ้าปากกว้างๆแลบลิ้นลงมายาวๆเลย
These videos showed her neurological examination. At the first video, we try to tell the patient to smile and also repeat after the examiner.
โอเคอ้าปากกว้างๆนะครับอ้าปากกว้างๆแลบลิ้นลงมายาวๆเลยค้างไว้แป๊บนึง
เดี๋ยวคราวนี้พูด
Okay, so this is the second video which the examiner told the patients to open and close her hand and then lift her hand up. And the last video is the gait of the patient. So we can discuss for the phenomenologies and also discuss for the etiologies in this patient.
ตามหมอนะเอาลิ้นเข้าได้
Answer.
Yes, your
Dr. Khan.
hand.
Okay, in this video, we can see the patient which have the difficulty in opening the mouth, have some dysarthria, but I think not only dysarthria, but difficulty like when speaking, and when the when the posture of the hands are the dystonic hand might be bradykinesia, but I think it's her bradykinesia due to her abnormal posture. And at the last video, the patient walks more slowly with the abnormal posture on pose of their hands and their foot. And I think in this video examination, the phenomenology is generalized dystonia. Okay.
Okay, all right. Can you describe the her face appearance?
Her face.
Yes, her face.
Her face is due to the dystonia, the low face, and maybe the generalized dystonia. I remember maybe the faces of the rhesus sardonicus. Rhesus sardonicus might be one of the size of in Wilson disease. Okay. I'm not sure what, but we're checking another examination and laboratory test.
Thank you. What about the eyes? Could you
comment? I'm not sure that's her examination on eye looking around or some ocular crisis. I'm not sure about that.
ยิ้มฟันโอเคยิ้มเต็มที่โอเคอ้าปากกว้างๆนะครับอ้าปากกว้างๆแลบลิ้นออกมายาวๆเลยค้างไว้แป๊บนึง
เดี๋ยวคราวนี้พูดตามหมอนะเอาลิ้นเข้าได้พูดตามหมอนะโรงพยาบาลจุฬาลงกรณ์
Okay, I'm not sure about it. When examination, you told the patient to look at that side. I'm not sure, but it appears spontaneously. Maybe it is the ocular crisis. I'm not sure about that. Maybe it might be. Yeah.
About the limbus.
Okay, the eye examination show the case of pressure ring. Okay.
Thank you. We move to Associate Professor in Min Ye for the discussion part. Please, Professor Ye.
Thank you. Please let me share my screen first.
Do you want to share your screen?
Yes.
Please share your slide.
Okay. Okay, here again, we present the phenomenology by the audience. Yes, she has some dystonic posturing of the lower face, difficult opening of the mouth, and she also has some torticollis, I think, because her head is turned to the right side in some occasion. And I also think the upward movement of the eyeball, is it voluntary or involuntary? At first, I think it is oculogyrate crisis. And her speech is very dysarthric. And in second video, there is dystonic posturing of the upper limb, more in the extremity, which is worsened by the action. She also has some bradykinetic movement of the hand, but no rest tremor, posture tremor, nor wind beating tremor. In the third video, she walked with dystonic gait. So you can see in the video, there is extension of the left big toe and hyperextension of the wrist and the fingers on the left side when you look closely. And she also has slightly reduced arm swing, and she has poor balance, especially when she turns around. So the phenomenology of this patient is oromandibular dystonia, jaw, especially jaw closing, mild torticollis, and generalized dystonia, which is asymmetry and predominantly on the left side. So she also has a peculiar facial expression with a raised eyebrow and sustained lower facial spasm. And it looked like a grinding of the teeth, which is a rhizus sartoricus. And we usually see it in the case of tetanus and in some cases of the Wilson disease. And so how do you approach with this patient? In this patient, we have to consider is the dystonia or other abnormal posture that can mimic dystonia. But I can say that this is true dystonia because in other musculoskeletal or orthopedic problem, dystonia is fixed. And if you define is the dystonia, the second thing is you need to assess for the, is it isolated or combined with other movement like Parkinsonism, ataxia, or myoclonus. Another thing is you need to look for the other neurological features like cognitive dysfunction or neuropathy. And the other thing you have to look for is there any organomegaly or the KF ring? And together, you have to ask detailed history about the temporal pattern of the disease, whether it's came in acute onset or the progressive onset. If it came with the progressive onset, you should think of the neurodegenerative or hereditary condition first. So in this patient, it came with progressive onset, about 5 years. So we should think of the same hereditary or neurodegenerative condition. And again, the distribution of the chorea, dystonia is very important in the etiological clue. And you should also ask for the detailed family history and the medication history. So after all these clinical evaluation, then you proceed to the syndrome specific structure investigation, which include imaging, laboratory workup, and the genetic testing to get the final etiological diagnosis. So this patient with prominent oromandibular involvement. So we should exclude drug induced. So we should have a detailed drug history. And we should exclude neuroacanthocytosis, which is typical feeding dystonia, but we don't, in this patient, don't have a feeding dystonia. And neuroacanthocytosis usually present within an old age. And we should exclude Wilson disease, and other MPIA disorder. So distribution of the dystonia is very important, especially oromandibular dystonia. In second and third video, there is jaw opening oromandibular dystonia in the young patient. So we always think of the Wilson disease in this age population. So it is important to look for the other systemic features like KF-ring. In this picture, it is clearly showed that there is a yellowish brown pigmentation at the corneoscleral junction in the descendant membrane. So if you see this sign, you can straightly go to the diagnosis as a Wilson disease. You also need to know about what are the reflex against the diagnosis of idiopathic dystonia, like anesthesia pattern, sudden onset, history or exposure to drugs, the presence of associated neurological or systemic signs, any prominent bulbar involvement, hemidystonia or such. In this case, the progressive onset dystonia in young adult with associated other neurological signs with hemianesthesia, and prominent bulbar involvement. So we need to exclude the structural lesion also. So this slide summarizes the diagnostic approach in the dystonia. So I cover all these things. So we clinical syndrome, and then we should look for the MRI and the Wilson screening by copper and ceruloplasmin first to get the etiological diagnosis. So going back to the case, young adult patient with progressive generalized numbness and tingling over 5 years, and dysphagias over 3 years, difficult walking and mouth opening for 6 months. Phenomenology is generalized dystonia, which is asymmetric, with jaw closing oromandibular dystonia and mild torticollis. She has associated hemisensory anesthesia and dysphagia. What about the cognitive function? So I haven't seen in the history that about the cognitive assessment. And she also has a negative history, and she didn't have no illicit drug use. So I want to exclude Wilson disease first, and I want to exclude structural basic ganglion pathology, and I want to exclude CNS infection and demyelination diseases like autoimmune encephalitis antibody and CSF study. And then lastly, all are negative, I want to proceed to the genetic testing. Thank you for attention.
Okay, please move to the answer of the case. Thank you, Dr. Ye.
Okay, so we perform the basic blood tests, including the CBC, the renal, liver, and thyroid function, which were all normal. And you see here that the serum ceruloplasmin was low at the level of 9.6, and the urine copper level is high at 148.25, about 2 times upper the normal limit. And the other basic profiles of the autoimmune and demyelinating panels were all negative. We also performed the ultrasound, whole abdomen, and fibroscan, which were not found the cirrhosis. For the imaging, the left one is the T1 weighted imaging, the middle one is T2, and the right one is the T2 flare. You see that there is asymmetrical hypersignal intensity lesion at bilateral putamen and thalamus in T2 weighted imaging and T2 flare. Also, at the central pons, there is also hypersignal intensity lesion, resemble to like what we call the dense line in the ODS, but it can be also found in patients with Wilson's disease. So with the laboratory results and also the imaging, this patient has Wilson's disease presenting with generalized dystonia, dysphagia, and also the abnormal sensation. So I'll only emphasize on the rare clinical presentation of this case because mostly patients will present with like dystonia, But patients presenting with sensory loss is very rare, and only 2 cases reports with a polyneuropathy, not the thalamic-like presentation in this case. So the investigation in these patients confirmed the Wilson's disease, and you all can review the investigation of the patients with Wilson's disease. So these patients was treated with D-penicillamine, slowly titrate to 750 milligrams per day, because in Thailand, we don't have transient. So we have to slowly titrate the D-penicillamine. And then we also add the vitamin B6 and screen for asymptomatic Wilson's disease. The patients has improved dystonia, dysphagia, and also gait abnormalities following up at the 4 months. Still good cognitive function. She can talk fluently, understand me. The cognitive is very good. And after her motor improved, now she can go back to work as previously.
Thank you, Dr. Warongkorn and Dr. Aye. This case is quite interesting because before she present with the abnormal movement, she present with the abnormal sensation and make her misdiagnosis of Wilson disease to be the multiple sclerosis. So you have to maybe clearly examination and carefully examination in this patient. For the 5th case is presented by Dr. Supata Metarakshi from Thailand, and also the faculty is Professor Norina Ibrahim. Okay, please start.
Okay, so moving to the next case, it will be short. A Thai woman with transient jerky movement. This is a 68-year-old Thai woman presented with subacute cognitive decline and abnormal movement during sleep. From the history, 2 months before the patient was present at the hospital, she had many episodes of the left arm stiffness and jerky movements. Then a month later, she began to have a recent memory loss, and 2 weeks later, she developed the problem when he sleep. And during the admission, there were a transient jerky movement on the left arm. She had a history of breast cancer and fatty liver. General examination were unremarkable. Also, the neurological examination. The cognitive test demonstrate cognitive decline, especially in the attention and recall memory. This is the video during the sleep. Okay, so what is the phenomenology in this video? Anyone to try?
I guess the patient might have REM behavior during sleep.
I will repeat the video. It's very brief movement.
They have results during sleep.
Yes. Okay. So moving to the next video. This is the video while she was admitted to our hospital.
They have resulting movement.
Okay. Are there any specific terms or signs of this movement?
ไปเที่ยวไหนมานะคะก่อนหน้านี้จำได้ไหมคะไปที่ไหนมาเล่าให้หมอฟัง
Okay, so it's a brief jerk-like movement. Okay. So discussion about the phenomenology. The first case.
Maybe we can get the discussion from Professor Narina. Could you please discuss this case?
Yeah. Actually, it's very clearly described. So what is happening is just a brief dystonic posturing of a left arm, which is very, very brief. It's about 1 to 2 seconds exactly during sleep. And when the patient is awake, you also could see her arm being pulled in a dystonic posturing. And the patient is aware during these episodes. And I couldn't see her face very well, but it's not very clear here. But it looks like seizures or REM sleep behavior disorder. But if it's a REM sleep behavior disorder, it shouldn't be present when she's awake. So it is not a REM sleep behavior disorder. So it is something else. So we have to consider things like seizures. What if it's a movement disorder, what other movement disorder that you would like to consider that would occur very briefly like this? So it would be a paroxysmal kinesiogenic dystonia, PKD phenotype. So this is, but she doesn't fulfill the PKD phenotype with a clinical syndrome. If you go back to her history, she started with this jerky movements, which initially could sound like myoclonus, but when you clearly look at it, it doesn't. It could be a focal twitch resembling a focal myoclonic twitch, but it's a bit slow. So that there is an overlap of a myoclonus, but the phenomenology is a dystonic posturing. So I would say this is a faciobrachial dystonic seizures, considering her cognitive decline over a period of time, and this would be consistent with an autoimmune encephalitis, particularly LGI1 encephalitis. We really need to exclude that. So we need her EEG and an MRI scan and an autoimmune screening for that.
Thank you very much. We move to the investigation.
The investigation show hyponatremia, and on the MRI finding, there was demonstrate an abnormality on the right posterior insular lobe on the flare, and no restriction distinction. This is the MRI report, and the EEG demonstrate neither seizure or epileptiform discharge. And we do the serum autoimmune encephalitis, and we found that the LGI1 were positive. So these patients were diagnosed as anti-LGI1 encephalitis present with subacute recent memory loss and faciobrachial dystonic seizures. And we to give her the immunosuppressive treatment, and her symptoms improved. And a brief review is I just previously said in my lecture. So the learning point is that the hemifacial dystonic seizure is a pathognomonic feature for VGKC complex LGI1 antibody encephalitis, which is a treatable disease. Thank you.
Okay. Thank you very much, Dr. Supatha and Professor Narina. I would like to add a little bit about the REM sleep behavior disorder. For the movement during sleep, is quite the common is the jerky movement, especially in the distal limb of the upper arm, but sometimes it's quite like the movement during the daytime, like kicking, running, or jumping out of the bed. It's likely to cause a dystonic posture for the REM sleep behavior disorder. In this one, I agree with Professor Narina that we have to differentiate between the seizure or not, because it's briefly and repetitively during the night. Thank you very much. Kate. Kate. So the sixth case is from Dr. Apiwood from Thailand. It's a short case.
Yeah. I would like to present my case from Somdet Hospital. This is a case of 42-year-old Thai female living in Silachar district, Chonburi province, presented with ataxia for 1 year and 3 months prior to this admission. Previous stated that she had been able to do normal daily activity. Patient unit, 1 year and 3 months prior to this admission, the patient had begun to have difficulty with walking, and she also claimed to have experienced instability when standing for a long time period. But she was still able to stand and maintain her balance in normal daily activities. She claimed no symptoms of dizziness or fatigue, nausea or vomiting or limb weakness. 4 months prior to this admission, she claimed to have worsening of symptoms. She couldn't walk normally. She had to use a gather for standing and walking. So she decided to go to hospital to work up about her symptoms. Partially, no past medical history and no current medication or no toxin exposures. And then the family history that I show in this slide, in this predicate, show that there are 2 people that have the same symptom like her. Her mother and her cousin, and the age of onset of her mother and her cousin is greater than her own case. In physical examination, other physical examination were normal. In neurological examination, good consciousness, follow 2-step command, cranial nerve all intact, motor file, no spastic tone, no muscle atrophy. No sensory loss, deep tendon leaflet 2 plus or Babinski Panta response board. And cerebellar side you can see in this video. โอเคมองขึ้นข้างบนลงข้างล่างบนล่างบนล่างบนล่างซ้ายขวาโอเคครับมองไปทางซ้ายลงน้อยๆนะมองตามปลายปากกานะครับโอเคคือเขาจะมีเป็นแบบมีเป็นแบบตาขยับอยู่ปุ๊บมองไปนี้นะครับมีแตกมัดเลยมองขึ้นข้างบนนะครับมองข้างล่างครับมองนะมองเข้าไปครับมองขึ้นมองลงโรงพยาบาลสมเด็จครับโรงพยาบาลสมเด็จโรงพยาบาลสมเด็จโรงพยาบาลสมเด็จยายพาหลานไปซื้อขนมที่ตลาดยายพาหลานไปซื้อขนมที่ตลาดกลับมาได้ค่ะกลับมานะคราวนี้เดินกลับไปอีกทีหนึ่งไหวไหมครับตั้งค่อยๆนะกลับมาครับเต็มที่นะไหวไหมไม่นิ่งจะไม่นิ่งนะโอเคครับหมูครับแต่นิ้วผมนะแต่จมูก As you can see in this video, this patient shows cerebellar side positive in slow sac head, normal pursuit, but positive in truncal ataxia, wide base gait, and impaired finger to note both sides, and no Parkinsonism. So discussion and in this patient, the patient presented with chronic progressive ataxia, and she had a family history that consistent with autosomal dominant pattern because of sign and symptom is in all generation, all genders, and anticipation. Anticipation refers to the phenomenon in which sign and symptom is earlier in the next generation and maybe become to more severity. And so when you discuss about genetic cause of that mode of inheritance is autosomal dominant. You have to think about spinocerebellar ataxia. And this patient had additional size slow saccade. You have to think about spinocerebellar ataxia type 1, 2, or 3, and especially type 2. In this patient, this is this phenomenology in this patient. I put this slide. And spinocerebellar ataxia that I have told you, we have specific maybe side that can consistent with spinocerebellar ataxia type 2 because of slow saccade. And investigation, CBC, lumbar puncture, liver function, available fiber normal. And MRI brain, MRI brain didn't show any abnormality, only of maybe a myotrophy of cerebellum. Electrodiagnosis in this patient, no evidence of demyelinating or axonal polyneuropathy except bilateral median neuropathy at least level. And serum protein electrophoresis show no paraprotein detect. Vitamin B12 level was normal. And other unclassified antibody and anti-glycoside antibody were negative too. And this patient, we send the genetic test to confirm diagnosis. And genetic test is spinocerebellar ataxia type 3. And we can find slow saccade in spinocerebellar ataxia type 3. Definitive diagnostic spinocerebellar ataxia type 3. And this case Mercado-Joseph disease. And I only, this is the most common subtype around the world and in Thailand. And additional signs that you have to be aware of this scar-tree is pyramidal and spiral sign, the retraction, nystagmus, and decreased saccade velocity, and the myotrophy, vasculation, and sensory loss. Thank you for your attention.
Thank you very much for your presentation. And this is the last one for the short case from Laos. Please welcome Dr. Apason again. And after this will be the closing remark. We will invite Dr. Thai and Professor Pitayasiri for give a short speech for us before we close our conference.
Okay, hello again. I'd like to share you some interesting video that I found when I was a resident. This is a 69-year-old wife. She came to our clinic because she has involuntary abnormal movement. She started to have a visual and auditory hallucinations since 2015 with the tremor at right upper limb. At that time, she feels her family told us that she had some kind of feeling slowing down in daily activity. So in 2016, she went to see internal medicine physicians, and she was given some treatment for her hallucinations, and she started to have the involuntary abnormal movement that is affected upper and lower limb bilateral, and it's also developed to her mouth. Her past medical history, she's been having a chronic disease such as type 2DM on medications, and her current medication was artane, haloperidone, mardopa, and risperidone. She started to have it in 2015 because of her hallucinations. Let's have a look at her video.
สังคมเนี่ยเติบโตมันไปมันได้โพดส่วนหลังมันก็โพดนั่นแหละสังคมเนี่ยเติบโต
And this is how she walked.
ตัวยังไงล่ะบอข้อเขาดีเนาะเพราะว่าแก้มัน
Since there are limited of time, I'm going to discuss with her phenomenology quickly. From the first video, we have seen that she has the involuntary hyperkinetic movement and unpredictable fall-like, and also the resting tremor on her right upper limb. And on the second video, she has the repetitive shivering motion and orobuccal dyskinesia. And on the third video, we have seen that she has some right upper limb action tremor. And on the last video, she has some cautious gait, class D. If you take a look at her hand, she has a stereotypic movement of upper limb. What will you next? This is always happen when we practice as how country that oops. Okay. Because of the financial problem, there is no further investigation performed. So in this case, can you make a possible diagnostic from her history and phenomenology? If yes, what do you think she had and what is your management plan? According to her clinical symptoms and her history, we thought that she has the generalized chorea with orobuccal dyskinesia. And she also had tremor of right hand and history of antipsychotic drug use. So her diagnosis is likely to be tardive dyskinesia because of drug-induced and on top of the Parkinson's disease. Our treatment plan is to reduce antipsychotic drug and give her clonazepam. So thank you
very much for this interesting case. If you can do the maybe functional imaging, maybe it can confirm in this case whether it's only the drug-induced movement disorder or the drug-induced movement disorder and underlying of neurodegenerative disease. So thank you very much for our presenter and thank you very much, Professor Norina. We have another interesting question from the online. Just two. Interesting. And like other. And one,
Okay, maybe I could read out for the audience. This is an online question submitting from the virtual attendees. Dear panelists, among all of the 13 clinical features listed, which do you think bears the greatest weight for the diagnosis of catatonia? Maybe Gidada, you can comment on that.
As I know that for the diagnosis of catatonia is not the mandatory criteria. It requires maybe 3 from the many list like 13 with for my opinion, I think the cataplexy and active flexibility might be the most important feature for the diagnosis of catatonia.
Yeah, and I think that in real patients, is many times we don't see the whole clinical feature, we don't see the whole spectrum. But I think that along with the clinical history that was suggested earlier in that case, and remarkable phenomenology there, even we see some of it, I think that probably that will help us reach the diagnosis. I don't think that all the feature needs to be present to be
not all
for the diagnosis.
Require only 3 features for diagnosis of catatonia. It may be with other evidence that suggests for catatonia.
Another question, I think this is a bit quite general. Dear all the professors, so address everyone here, all the professors, in your experience, could you please highlight any of common movement disorder that impact voice, speech, and swallowing function? So that's many. I give to Dr. Lim then. Before closing.
I think most of the movement disorders can present with abnormal speech, whether it's Parkinsonism, dystonia. I think these are the two common ones. I think a few years back in the PRD, they had a sort of an atlas of the abnormal speech that you can actually view over there. Yeah.
I think what we see the examples today that many of the disorder they can impact the axial function, and that you know and patients can have this speech balance and coordination and so on. All right, I think that that's the end of the video session. Must thank our expert panel, particularly the one from the virtually. Professor Ibrahim, thanks very much. Dr. Ye, thanks very much. Thanks for your contribution.
Thank you very much, Professor Ibrahim.
Thank you. You're welcome.
Thanks, Dr. Ye, too.
Yeah, thank you very much.
Thank you, Professor. Thank you.
Yes.
You can join the closing. You are welcome to join the closing virtually.
So before we...
Yes. Yes, okay. We have 1.5 days for many interesting presentation. Do you think so? Yeah. And Vietnamese neurologist, Vietnamese doctor, do you like to have another meeting like this in the future? Yeah. Yes. I think we have 1.5 days for many interesting presentation, many interesting cases discussion. So I hope all of you and very happy to join this conference. For a short time, I would like to thank everyone, speaker, faculty, and especially all participants to come here for the conference. And I just say to thank so much for all. And I also hope to have the new the conference in near future for us. Thank you very much.
Just a few words to say that I'm actually very impressed with the quality and the active participation of the audience, you know, both on site and virtually. Many good discussion, many good questions throughout 1.5 days. But I think that the event that you have here today, Thai, is not just only the series of lecture that we, working on. What we actually gain from this conference is a collaboration, is a networking among countries within Indochina, which we have not had this officially, and I must thank you as the host of the first Indochina Movement Disorder Conference for the effort that you put in with the organization. Thanks to your team, I know that a lot of people involved locally, and also Latta Singh, I must thank you for connecting all the speakers once again from all the Indochina. And obviously we need to thank all the faculty, both here and virtually. I know that they take out their time, take out their weekends to come here, and obviously you have a superb team in Ho Chi Minh here, and we have a great audience today from all across Vietnam and Indochina, and I'm sure that the event like this will happen again. So thanks again.
Yeah, Dr. Lim Thiên Thiên, do you think, do you agree we will have the next conference in the future?
All right.
Yes, I also would like scientific research department in our hospital for support to organize the meeting, and also all the pharmaceutical company. Yes,
Yeah.
thank you.
So don't let just the conference be just the event that we come in and join the discussion and that's it. I think that we can see and we can learn a lot from this, and hopefully this will pave the way for our future collaboration. So maybe before we end, we can hear a few words from our Cambodian colleagues about this Indochina Movement Conference. Any suggestion?
Thank you. That the events that share our knowledge to Cambodian neurology, because we have this topic is very interesting, because in our country we have a focus on stroke and epilepsy. Now we have movement disorder is very important related to some of a patient. We meet a lot of patients but not register for this meeting, and epidemiological of Parkinson's disease in our country. But now we will start to link with movement disorder in the future, maybe. Okay, thank you, and I will support and thank organizer and the team of this conference, and especially for them in the team from Chulalongkorn. This is very important. Thank you. I will cooperate in the future. Thank you.
Any words from Malaysia?
Oh yeah, yeah. I have to really thank Dr. Tai and Dr. Girada for organizing this event, and of course Professor Rong Ruch, who has been the one who inspired this event to happen in the first place. And I'd also like to thank all the others faculty from Cambodia, and I've made a lot of friends and also learned a lot from the conference. So I hope that this will continue to go on, and then we could also collaborate in some other researchers and also function. Thank you.
Okay. You want to have some more?
That you said enough. We say enough. Say more.
Okay, I would like to say thank you to Dr. Thaitan and also Professor Lungrod, and to having me as a secretary of this conference. And it's like before we start this conference, it's like half a year ago, and we have a lot of preparation for this conference to make it perfectly. But I think it's very knowledgeable for you all and very effective. And I have a lot of experience to be the secretary in this conference. And I would like to say that it's a good opportunity for me and also for the young generation in our region to have an opportunity to be faculty presenter and in the international conference like this. So I hope that we will continue the next time conference.
Yeah, thank you, Girada. Yeah, I think all of you, not only me, not only Professor Vilayasri, all of you made the conference very successful. we will finish the conference. I hope to see you again.